Hello, my name is Alan Prost, and I'm creating this short video on factors controlling inspiratory flow and the mode of pressure control. Now, before we can discuss the factors that affect inspiratory flow during the mode of pressure control, we have to actually really understand the mode of pressure control very carefully. Sometimes it's abbreviated as PC-CMV. All right? Now, the pressure control we're going to talk about is an absolute pressure control level. There are some ventilators that allow for the delta pressure to be established, but we're going to talk about ones where we set the absolute pressure control level at the lungs. We also set a rate on the mechanical ventilator, so how many times the pressure control level will be achieved. We set a TI, which is the amount of time allowed for inspiration to occur, not necessarily the amount of time it takes for inspiration or inspiratory flow to occur and decline. We also set the PEEP level, and we set the FiO2. We're not going to discuss the FiO2 because it doesn't affect the inspiratory flow in any way. So in this slide, I'm going to try to describe how the mode of pressure control works. All right. First off, we have our ventilator controls that we've established, and then graphically down here, I'm going to show you how we have pressure on the vertical axis and time is along here along the horizontal axis, and so this is just a graph of pressure over time. Now, we've established our pressure control level for this example to be 25 centimeters of water pressure. So that's our maximum pressure that we'll have in the circuit because we're using an absolute pressure control ventilator at this time. All right? Our baseline pressure, or our PEEP level, is established at 5 centimeters of water pressure. Our TI control tells us how long we're going to hold this pressure. So the ventilator will be going along here at baseline pressure, and then it'll be triggered, time triggered, into holding the pressure and increasing the pressure in the circuit to 25 centimeters of pressure for 2 seconds, and then it'll allow exhalation for 3 seconds. All right. Our rate control establishes our total cycle time, which is in this case 5 seconds. So the breath will be given every 5 seconds. So a new breath will be given every 5 seconds for a rate of 12 breaths per minute. So now in this slide, I'm going to show you how we've got our regular pressure over time graph here that we saw just in the previous slide. Here's our ventilator settings. They haven't changed. But I also wanted to introduce for you the concept of our flow. All right. So here we have time triggered, and so we have the inspiratory flow, and it builds up quickly and then declines slowly until we have an inspiratory pause, and that's a critical element where there is no flow. All right, then we have exhalation occurring. So every 5 seconds, we're going to have inspiration, a little bit short inspiratory pause during that inspiration, then exhalation occurring. All right. Down here, we've got a volume. So our volumes are going to be given, and it'll be building up as long as there's flow, and that'll occur. And then we have a little bit of an inspiratory pause where the breath is held in place because we're holding our pressures at 25. And so the breath will be held in place, and then when the pressures drop back down, we'll have exhalation occurring at this time. All right. So in this case, I'm showing that we've got our pressures in our circuit are going from 25 being held for 2 seconds, then exhalation for 3 seconds. Initially, we're going to have a high inspiratory flow rate that's going to decline until we have an inspiratory pause, and then at the end of the 2 seconds set by our TI, we're going to allow exhalation to occur. All right. During that inspiration, we're going to have as the flow is on, we're going to have the buildup of the volume in the circuit and volume in the lungs, and then it's going to be held for a short period of time and then allowing exhalation to occur. All right? So those are the complex relationships established by our ventilator controls. So in this slide, I'm going to introduce a couple of new elements, and we're going to take a close look at the inspiratory flow, just separating it out from all the other waveforms that we've been looking at. So when the ventilator first clicks in and we first trigger our breath, we get a very high or a peak inspiratory flow established. And I'm going to describe why that occurs. And then we get this kind of logarithmic decline in inspiratory flow until we reach a flow of 0 where there's no longer any flow. Now the key elements here is this peak inspiratory flow is an important factor, and this time here, this TI dynamic. Now this is not the TI we established on the ventilator. This is the TI that it takes for the flow to initiate and then decline back down to 0. So we call it the TI dynamic, or the amount of time when there's actually flow established between the ventilator circuit and the patient's lungs. Now, for us to understand what's going on during inspiration, we really have to understand some of these key equations. And some of the equations I'm going to put out here is that TI dynamic, the amount of time that there's inspiratory flow occurring during that TI that we set on the ventilator, is the result of something called a time constant. And it's actually 5 of those time constants combined together that gets us the full inspiration or the maximum filling of the lungs. All right? So I know that might be a little bit abstract, and we'll explore that a bit more in the next few slides. Now, a time constant, which we are referring to here, is made up of the resistance, and that's the resistance of airflow into the patient, and the compliance of the thorax or the lungs within the patient, both of those combined. All right? So the time constant takes into account this relationship of resistance and compliance. All right? Now, if we tease out those two elements, the resistance here, we know that's the pressure gradient when there's flow occurring. All right? Now, that's an important concept, that we're only examining this when there's flow occurring. And initially, this pressure gradient in here is very high. So we'll talk about that in a second. Compliance is the change in volume divided by the change in pressure. Now, this is measured most effectively when there is no flow. So this would be often our tidal volume delivered because of this pressure gradient established between our pressure control level and our PEEP level. All right? But this is at a time when there is no flow. That's the best time to measure compliance. So what we want to talk about initially here is our peak flow. And the pressure gradient we're talking about is when we have that triggering of the ventilator is just starting initiating the breath. We've got a huge pressure gradient between our pressure control level and our PEEP level. All right? Now, the resistance is going to limit or it's going to establish how long it takes to get flow past that pressure gradient. So let's look at resistance. So on this slide, you can see I've got the equation here for flow, and it's the pressure gradient over resistance. All right, so I've rearranged our resistance equation to show how we can tease out flow, and this is just a short form for flow. All right, so we need a pressure gradient to establish flow, and we need it across a resistance. All right, because if there was no resistance, as soon as there was a pressure gradient across here, the molecules would just go into equilibrium. So P1 would equal P2, and there would be no flow. So we need a pressure gradient to have flow across a resistance. That's the key element of this diagram here. So in this slide, I'm trying to demonstrate the differences and put it in context of our mode pressure control CMV. All right. Now we're talking about before the breath is initiated, so during the expiratory time, TE. All right. So the ventilators established our PEEP pressures of +5, and we have equilibrium between lung pressures and the airway pressures or the mouth pressures. All right. So they equal each other. So at this time, there is no flow. So here now we're going to establish what happens during inspiratory time. All right. So here we have exhalation still occurring. There's no flow between the ventilator or mouth pressures and the lungs because they're in equilibrium. But now, once we've established right at the beginning, once the ventilator is triggered into inspiration, we have this large pressure gradient between the ventilator, or the mouth pressures, and the lungs themselves. All right? So it's this large pressure gradient across the resistance, which is usually the endotracheal tube, that creates that flow. All right? Now, once the lungs start inflating, the pressure inside the lungs is going to start to increase. That's going to decrease our pressure gradient. All right? Now, we've established our pressure control level at 25, so this is going to be held for our 2 seconds, because remember our TI established was 2 seconds. And then at the end of that, or just before the end of that TI, we have equilibrium between the mouth pressures, or the ventilator pressures, and the lung pressures. So once again, there'll be no flow. So on this slide, we're going to establish what happens during that TI. Once the TI, or once the breath is initiated and time triggered, what occurs? So right now, we are in our baseline pressures here, so we have equilibrium between the mouth pressures and the alveolar pressures. And then once the ventilator triggers into inspiration, we have this quick build-up to a peak inspiratory flow, and that's due to this high pressure gradient between the mouth pressures and the lung pressures. All right, so here we got a delta pressure of 20 centimeters of water pressure. So that delta pressure creates a high pressure gradient across that resistance. So we get a high inspiratory flow. Now, once filling begins, we have this decline in flow rate because we have the pressures in the lungs building up during this time. So as the pressure gradient decreases, so does flow. All right, so once our pressure gradient between mouth pressures and lung pressures starts to decline, we get a decline in inspiratory flow right up until the point here when we get equilibrium between mouth pressures and lung pressures, and that gives us a flow rate of 0. So once our delta pressure is equal, there's no pressure gradient, we have no flow. So initially, we start with a very high flow because of this high pressure gradient, and then it slowly declines as the lungs fill because the pressure in the lungs is going to be increasing. So we get this natural decline in inspiratory flow. Take a good look at our flow waveforms, our calculation, and you'll see that it's all due to this pressure gradient. And here, of course, we're establishing that resistance is not changing. It's a constant in this relationship. So what we've learned from that other slide is that if we have a high pressure gradient, such as our pressure control level set at 25 and our PEEP of 5, at the first start of inspiration, our high peak inspiratory flow rate is due to a high pressure gradient. If we have a low pressure gradient, such as a pressure control set at 10 and a PEEP of 5, we're going to have a low initial peak inspiratory flow. And then, of course, it's going to decline once the pressures in the mouth the pressures in the lungs start to increase and become closer and closer to the pressures in the mouth until eventually they become in equilibrium. All right? So flow is a result of this change in pressure over resistance. Now our resistance being constant, all right? Initially we have a high pressure gradient, so a high peak inspiratory flow, and then as the lungs start to fill, that pressure gradient is going to decline, and so we're going to have a declining inspiratory flow. Now we're not quite done with the factors that affect inspiratory flow, because what about the duration of inspiratory flow? All right, so we talked about how we know and the factors that affect the peak inspiratory flow, but what about the TI dynamic? What about how long it takes to get our flow rate to decline to 0? All right, and that's our TI dynamic. That's what we're looking for here, is how long it takes for it to go from a high peak inspiratory flow back down to 0. All right, and we know from our equations that that is our time constant times 5. So let's look at those factors. So here I'm going to describe for you in words what our TI dynamic is. It's the relationship or the duration of time it takes for mouth pressures to equal lung pressures. All right, another way to state that would be the time it takes to equalize the ventilator pressures and the pressure in the patient's lungs. All right? It's the amount of time that there's flow occurring between the patient circuit and the lungs. All right? So the amount of time during the inspiratory phase of ventilation when there's flow. All right? It's the amount of time it takes to deliver the tidal volume. This is not the TI set on the ventilator. This is TI dynamic. All right? And it's that relationship between how long it takes for the flow to go into the lungs and establish the volumes to be or the pressure in the lungs to build up until we get equilibrium between mouth pressures and lung pressures. Now we've been talking a lot about this TI dynamic, and we know now that it's the time constant times 5. All right, and the time constant is made up of resistance and compliance, and here's those same basic equations again. All right, so we're going to explore these relationships to tease out exactly what factors affect the inspiratory flow during pressure control. So an examination of that time constant, where we have resistance times compliance to make up that time constant, what this equation tells me is that if there's an increased resistance, we're going to have an increase in the time constant. All right? And that's going to cause an increase in our TI dynamic. All right? Time constant is a relationship, and it describes how long it takes for our TI dynamic to occur. The other part of the time constant equation is compliance. All right? So an increase in compliance will also cause an increase in our time constant or an increase in our TI dynamic. All right? Now this compliance is, of course, our patient's combination of our patient's thoracic and lung distensibility or elastance. So when we're discussing the mode of pressure control CMV, what we're discussing is this relationship of the pressure control level over the PEEP. That establishes our delta pressures. All right? We know that our delta pressures control our tidal volume in this mode, and as we've discovered, our delta pressures also are a major factor in describing our peak inspiratory flow rate. All right? So if we increase our delta pressures, we are going to increase our tidal volume, and we're going to also increase our peak inspiratory flow rate. If we decrease our pressure gradients, we're also going to decrease our tidal volume delivered to the patient, and we're going to decrease our inspiratory flow. And these are those basic factors that I was looking at that we wanted to tease out for the factors that control inspiratory flow in the mode of pressure control CMV. Now, in the mode of pressure control CMV, the resistance is mostly due to the endotracheal tube. All right? And so that's mostly a constant. There's not much we can do about that resistance. Also, the compliance is due to the lungs and the thoracic nature of the patient's chest wall. And that we don't have much control over either. But this will change due to pathology. The resistance doesn't usually change in our circuit when we have the mode of pressure control CMV established on our patients. So what this means to me in pressure control CMV is that resistance, there's not much I can do about it. And it's not usually a variable as endotracheal tube is constant. So we're not going to talk about it very much because it doesn't change very much. I mean, the patient might bite down on the endotracheal tube. Certainly it has a factor if you used a larger as compared to a smaller endotracheal tube. But once the mode of pressure control CMV is established on a particular patient, the resistance is usually established and set. So if I wanted to discuss and abbreviate the factors that affect inspiratory flow in the mode of pressure control, I would break it down into these two groups. Changes in our delta pressure, which is our pressure control level over our peak, establish our peak inspiratory flow. All right? They also establish our tidal volume, but for our purposes in this discussion, it's the effects on peak inspiratory flow that's important. Changes in compliance are going to cause a change in our TI dynamic. So changes in patient's compliance is going to directly affect the duration of flow more than the peak inspiratory flow or the flow rates themselves. The changes in patient's compliance are going to affect the duration of inspiratory flow or our TI dynamic. So let's take a look at those relationships. So I know this is a very complex slide, and we're going to see how here we've changed our ventilator settings. So I have three ventilator settings, one with a delta pressure change of 15 in the green, one of a delta pressure of 20 in the blue, and a larger pressure gradient of 25 in the red. So this establishes, because here this is directly relates, that pressure gradient establishes our peak inspiratory flow. All right? And I looked at it over a variety of resistances, and I've established just a set compliance here. So compliance is our constant here. And you can see it changes our time constant, and here's our time constant times 5. All right? So changes in resistance does affect our peak inspiratory flow. All right? It changes our flow rate, and it changes our TI dynamic. All right? Changes in our ventilator pressures, the difference between the red, blue, and the green here, the changes in our pressure control level affect the peak inspiratory flow, not our TI dynamic. All right? Now, normally, for most patients, we're going to have a kind of a set resistance. That's not going to change very much. So you might want to look at this diagram. It's a little bit complex, and it takes a little while to digest. Now, in this complex diagram, once again, I've established the same ventilator parameters here. And this time what I've done, though, is I've kept the resistance constant. So I kept it at a resistance of 8. And what I did was I changed the compliance to show how changes in compliance change our TI dynamic. All right? Changes in our pressure control level simply vary the peak inspiratory flow. They don't alter our TI dynamic. All right? So that's simply what's occurring in this rather complex diagram. So I've established larger pressure gradients here in the red here. I've kept the resistance and compliance all the same. So if we look carefully at that, you can see I've got a certain tidal volume. All right? And as I adjust the pressure control level, I'm going to change the tidal volume established and that peak inspiratory flow. But my TI dynamic does not change. So when I change the pressure control level, for most of my patients, their compliance is going to be constant. The resistance will be constant. So what I'm going to change when I change that pressure control level is I'm going to change the peak inspiratory flow. I'm going to change the tidal volume delivered for my patient, but I'm not going to change the TI dynamic or the length of time it takes to get distribution of ventilation or the pressure from the mouth into the lungs. That's what this diagram shows for us. Okay, my name is Alan Prost, and I was just here trying to describe for you the factors that affect inspiratory flow in the mode of pressure control. Thank you very much.